Definitely do some negative recruiting to that.
Okay. So welcome to everyone who's joining us online. Potpourri this morning, which is good because that's kind of real life. Okay, everybody, first off, let's get ourselves focused up on the scope. Okay, everybody got their eyes in? That way we're all attuned to the monitor and the path guys streaming it and everyone else. I see some others twisting. Okay. Everyone good? Okay. So, Shane, you want to start us out?
Sure. So, pretty broad, actually very broad.
And where do you think it is, probably?
It's like scalp.
Yeah. So, probably scalp, quite broad.
There are melanocytes there.
They certainly are producing pigment and they're nested.
They also are, I don't know. It's very broad, but it is on the scalp, so they can be kind of weird.
Broad, it is on the scalp. Is it all in nests, or is there somewhat interstitial at the base? So it's a little bit patchy, discontinuous, interstitial, quite broad, but the melanocytes are bland. And in areas, they're all through a rector pili muscle. Like a congenital nevus. Very good. Well done.
This looks like a fibroepithelioma of Pemphigus.
So fibroepithelioma of Pemphigus is actually a very good thought because you have long strands with eccrine duct and sweat, and fibroepithelioma is pink strands, blue buds, and there are definitely eccrine ducts in the strands. So that's definitely in the differential. What if there are no blue buds, though? What if this is just the vertically oriented eccrine ducts? And one of the hints, it may not be a Pemphigus tumor, is it doesn't anastomose as much as a Pemphigus tumor. They just kind of sneak downward.
Okay. I'm not sure what else we're doing.
Anyone want to jump in?
Mascaro?
Yeah, Mascaro tumor. Syringofibroadenoma of Mascaro. So syringofibroadenoma of Mascaro is long, snaky eccrine ducts in a fibrous stroma. So syringofibroadenoma kind of says the whole, gives you all the components of the tumor. So syringofibroadenoma and Pemphigus tumor share the strands of eccrine ducts. Pemphigus tumor has blue buds at the tips, and they tend to anastomose, whereas the syringofibroadenoma, they snake downward, but they don't interconnect and anastomose.
The vascular, there looks like there's increased vascularity to this. Is that just location? Are we on the leg and that's why we're getting it? Or does this tumor actually have increased vasculature to it?
You can have a little bit of increased vascular, but most of this is just leg.
Okay.
So you pointed that out exactly correctly, that you're seeing a little bit of nodular angioplasia as a clue that you're on the shin, 99% of mascaro tumors are on the lower leg.
So you're going to see it, but it's not necessarily associated with the tumor.
In fact, whereas mascaro tumor kind of sits right on the border of, is it reactive, is it neoplastic? With time, they begin to look very tumorish and grow like a tumor. But in the early stages, a lot of them look like a curious type of pseudoepitheliomatous hyperplasia dystasis that's all ecrine duct. Okay, how about this one?
So this is a punch biopsy.
Yep.
Rather squared. Looks like you have almost granulomatous infiltrate in some areas.
So very good. So it's a little bit squared off, but still tapers. Is it top to bottom, side to side, or is it more focal and patchy?
It's more focal and patchy, so it's
And the blue stringy stuff in there?
there's mucin in there. So I favor GA.
Absolutely. So favor GA. If there were more neutrophils in there, you might think of PNGD, palisaded neutrophilic and granulomatous dermatitis, which is kind of a GA variant. It's not quite square enough, layer cake enough, or top to bottom, side to side enough to be NLD.
Okay. And for palisaded granulomatous dermatitis and like GA or NLD, do you feel like those, like obviously NLD and GA are a distinction we need to make, but palisaded dermatitis, granulomatous dermatitis and GA, is that a distinction that, okay.
So your question is, is it fair to expect someone to distinguish PNGD histologically from GA? Not necessarily.
Okay.
Whereas NLD GA,
Yes. Right.
absolutely. So this one is an NLD GA question. NLD GA distinction, NLD would be layer cake, top to bottom, side to side, square biopsy, whereas GA tends to be a tapered biopsy, focal and patchy, palisading and interstitial granuloma, mucin in the areas of collagen degeneration.
Looks like ochronosis, possibly. That could be just pigment. Yeah, maybe not.
You need the higher power views.
Yeah.
Yeah, but that's fine. Anything that you do here, you'll do in real life as well. So, make all your scan mistakes at this scope so that you don't make it at some other scope. And then, we'll talk through why your eye led you one direction.
Okay. So you sort of have it looks like sort of almost a wedge-shaped pigment.
Yeah, kind of wedge shape.
So I was thinking like blue nevus.
Yeah. So does it have its own red ropey collagen that's different from the surrounding elastotic
Yes.
tissue? And that would be normal for a blue nevus. And that's probably the best hint at scan that you're not looking at pigment deposit on elastic fibers for ochronosis, but you're looking at dendritic melanocytes of a blue nevus, is the stromal change in the collagen. Ochronosis purely affects the elastic tissue. There is no collagen change. Whereas here, at scan, you've got a very blue elastotic collagen, and yet you see red ropey collagen within a roughly wedge-shaped, pigmented area. That's likely to be a blue nevus because of the collagenous change at scan. And a lot of this is, what are the hints at scan that you pick up on that already give you the diagnosis before you go to high power? Okay.
All right. So a punch biopsy. Looks like there's some areas in the dermis that almost look like cartilage to me.
Yep. Agree. So cartilage in the dermis.
We have an ulcer.
And there's an ulcer. What's at the base of the ulcer?
Looks like some fibrin.
Fibrin, and adjacent to the fibrin?
Granulation tissue, some
Yeah.
inflammation. So, like CNH,
Exactly. So CNH, you don't have to see the cartilage. This one's a gift and a giveaway because the cartilage is there. It would be very fair just to see from about the arrow up where you have an ulcer, you have fibrin under the ulcer, forming roughly a column of fibrin, and then granulation tissue flanking it on either side. That would be, completely diagnostic and fair as a biopsy specimen for CNH without the cartilage there. If you have the cartilage, it makes it easy. Without the cartilage, it's one step harder, but still diagnosable. Okay, so it's a little fragmented.
Right. So see maybe a malproliferation of sebaceous glands.
And I'm also thinking that it's not so much that the skin's folded over as this actually is a cystic space filled with keratin. And then this is the cyst wall rather than surface epidermis.
Okay. So maybe like with adnexal structures, maybe like a dermoid?
Yeah, exactly. Focally, I see a shark tooth type cuticle. Name two cysts that can have that shark tooth?
So steatocystoma and dermoid.
Yeah, steatocystoma and dermoid. So it's perfectly normal to have that in an area of dermoid, but dermoid also has all those adnexal structures. Does steatocystoma have any adnexal structures in the wall? Sebaceous glands and vellus follicles, but you'll never see eccrine, and you'll never see terminal follicles in steatocystoma. And here you can see terminal hair follicles, big pigmented hairs, not just vellus hairs. So the fact that they're terminal hairs favors dermoid over steatocystoma. But steatocystoma can have little vellus hairs. If you look at the contents that comes out of a steatocystoma, it's oil with vellus hairs. Kind of tells you what'll be in the cyst wall. Whereas a dermoid is keratin filled instead of oil filled, and you see the keratin here, has terminal hairs, and may or may not have eccrine glands. So it can have all the adnexal structures that skin has. Okay, Brian.
So, pretty squared off punch here.
Fairly squared off punch.
Very pale. The papillary dermis relatively effaced, and then busy dermis. So I'd put this similar to before into the GA category. It's kind of
So why GA? You said this one's fairly square, which I agree with, and yet you correctly said this was GA and not NLD. So even though it was a little bit more square, what led you to say that this was GA rather than NLD?
It just, to me, it looks more palisaded and a little bit more organized. It doesn't have as much of a layer cake appearance as it is like with an interstitial
So it's more
component.
circles rather than layers. So palisaded circles rather than layer cake layers. And is it top to bottom, side to side, or do you have areas of normal collagen?
Yeah, it looks like it does get a little normal at the bottom.
Yeah. So the patchiness and the fact that they are circular palisaded granulomas rather than parallel layer cake, both of those favor GA over NLD. Also, presence of fibrin would be something you can see in deep GA, so mucin and fibrin you see in GA. Fibrin you also see in rheumatoid nodule. You wouldn't see fibrin in NLD. And this one had some fibrin in the granuloma. So that was another clue.
Looks like superficial vascular infiltrate.
So you got a superficial perivascular lymphoid infiltrate.
Porokeratosis.
And the porokeratosis is confluent or sitting on top of ortho?
Sitting on top of ortho.
So you got para sitting on top of ortho. What does that suggest about the timing of the lesion?
More chronic.
Yeah, more chronic, and also something that's not persistent, but more kind of
Comes and
intermittent. That comes and goes. And so if you saw neutrophils sitting on top of that mound of para, what might that suggest?
Like psoriasis.
Yeah, especially gut
Psoriasis,
tape.
yeah.
And in this one, you have distinct absence of neutrophils. So what do you think of that? There are little bits of sponge here, but just focal.
So maybe like PR.
Yeah, like PR or really any spongiotic process that's now going into its resolution phase. So the sponge has kind of left, and your corneum's getting normal, but you still have that history of the porokeratosis telling you stratocorneum takes about 2 weeks to turn over, so about a week ago something was going on there. Right? So this would be a hyperkeratotic but not actively oozy area of spongiotic dermatitis. And you may not see a lot of sponge, but you still have the porokeratosis as history.
So, it scans to me, it looks like it has some sebaceous differentiation there centrally.
So, you definitely putting it into the adnexal tumor category, and it's, in this one, it's a little challenging. Is it more red or is it more blue? This one's kind of in the middle, amphiphilic. If it were blue with ducts, we would definitely say sebaceoma, right? Red with ducts, you'd be more acrospiroma. So we have to go a little higher, look for sebaceous differentiation. What might be stains that would help with that?
You can get a CEA.
So
ducts.
CEA would be very good for ducts. That would be very good in acrospiroma for ducts. And it looks like you have some little intracellular ducts. You definitely have some bubbly cytoplasm that looks like it could be sebaceous. So other things like an EMA, highlighting those vacuoles would be really good evidence of sebaceous. The other thing that could help is 13A nuclear staining is a newer marker for sebaceous differentiation. So all those things could help.
That one was labeled sebaceous.
Let's see what it was labeled. It was labeled sebaceoma. That's what they called it, with those little vacuoles there. I can believe it. That one though, because it's as pink as it is blue, I probably would have done a stain to see if those were fake or if those were real sebaceous differentiation. So for me, it probably would have been an EMA.
This is a pretty tight superficial perivascular infiltrate that actually there's some newts in there, and it looks like it's, the vessels are being affected with maybe some fiber deposition. So some of it almost has an LCD look. It's got the K-erectic debris.
So it's certain. Sorry, I should not speak and swallow at the same time. So there are neutrophils, there's K-erexis, there's red cell extravasation suggesting vascular damage, maybe a little bluish amphiphilic hue suggesting a little fibrin. So leukocytoclastic vasculitis, how would it differ from urticaria, which is neutrophilic?
You would not have the fibrin deposition.
Fibrin or K-erexis. How would it differ from sweets?
Well, sweets should really be kind of wall-to-wall newts with K-erectic debris and more of a secondary vasculitis.
And what else is present in sweets that's absent here?
Oh, the marked papillary dermal edema.
Yeah, the papillodermal edema, which is really what hits your eye. Things with incredible papillodermal edema. If it's neutrophilic, you think sweets or bowel bypass. If it's lymphoid, you think PMLE or pernio. And pernio is usually acral skin. So that's usually a hint for perniosis. Tinea can also do it, so that would be in your differential. How does it differ from things like Still's disease that are also neutrophilic?
Well, Still's, hopefully you'd have some epidermal change, either the whorls or some of the dead reds.
So Still's, very characteristically as it evolves, gets individual necrotic keratinocytes. Those become whorls of keratin. So it looks a little bit like incontinentia pigmenti with the whorls of keratin in the corneum and the individual dead reds. Early on, Still's is neutrophilic but lacks karyorrhexis, lacks fibrin, usually lacks red cell extravasation because there's no actual vessel damage. And karyorrhexis and Still's really don't go along together. It should be neutrophilic without much of any karyorrhexis. Still's also, clinically they have periodic fevers, they may or may not have arthralgia, they have a sky-high sed rate, and they have a ferritin through the roof. Their ferritins are higher than hemochromatosis ferritins in Still's. So, that also helps when you get that clinical picture.
Ooh, there's a coronoid lamella.
There is a coronoid lamella right there. Oops, let's get it in the field there. Right under the scratch is the coronoid lamella, and yet your eye went right to it, which is good. So, remember, center of poro can look like anything. It's frequently lichenoid, atrophic, can be psoriasiform, can be hyperplastic. So you always look for the coronoid lamella at the edge.
So we have subepidermal bulla there.
So there's a subepidermal bulla. Is it forming as a result of DE junction basement membrane separation, or forming as a result of destruction of the basal layer?
We have infiltrated
So
the basal layer in some areas looks intact, like on the right there. But then
So is the basal layer usually flat or usually columnar?
I guess cool.
And here it's flat, so you have squamatization suggesting that rather than the basal layer being intact, it's totally gone. So all that's left is the upper squamous layers.
Okay.
Okay, so this is so-called squamatization, where your basal layer has been chewed away. Here you can see basal layer intact, columnar at the edge. Towards the center, you've lost it. You have squamatization. You've got sawtoothing. You have a band-like infiltrate. You have dead reds. So what kind of infiltrate?
It's a lichenoid.
So it's a lichenoid infiltrate. So what things can give you a lichenoid dermatitis?
Lupus or
So lupus
drug.
can. What else?
LP drug,
LP drug.
regression of melanoma,
Regression of melanoma if it's broad on sun-damaged skin. Lichenoid GVH. History is usually a big help there. And solitary on the chest, rule out basal. Benign lichenoid keratosis, lichen planus-like keratosis. One of the hints for that is that the corneum is not uniform. It's all mixed up. It's a little compact. It's a little parakeratotic. It varies from bit to bit. So, this would not be bad for BLK, but you always have to look at history and what does it say? Oh, it looks like LPLK. Yeah, which is same as BLK. I just always say BLK because it's one less letter. Okay, so what do you think the stain is?
It's blue.
It's blue. So what kind of blue stains do we have?
It's like the trichrome, whatever, the stains collagen.
Trichrome stains collagen blue. Do you think that's collagen, or do you think that's kind of chunky perivascular stuff?
I think it's the latter.
More like chunky perivascular stuff. So probably what kind of blue stain?
I don't know.
So anyone want to jump in. Probably something staining iron, right? So there aren't that many blue stains that we have. So as you mentioned, trichrome can stain collagen, kind of blue-green. But here it's not the collagen that's staining. About the only other thing we have is Prussian blue, also called pearls, also called ferrocyanide, all the same thing. It stains iron. In fact, that's how cyanide kills you, is it binds the iron in your blood, so it can't carry oxygen, right? So ferrocyanide is completely benign, not toxic, because it's already bound to iron, right? Can't hurt you because it's already iron bound. Colloidal iron, the way you stain for mucin is you take colloidal iron, put that on the slide, that stains to the acid mucin, then you stain it with an iron stain. That's why the colloidal iron stain looks blue, because it's a two-stage stain. You're putting colloidal iron there, that binds to the mucin, then you're just staining it for iron. Okay. Here, it looks like there's lots of chunky iron around vessel, like the kind of thing you might see in stasis, in targetoid hemosiderotic hemangioma. It's something with iron deposition. And it's in this case, the iron was exogenous. It was a Munsell's tattoo. State.
I know it's not me. Mine passed with my answer being pearls.
Looks like a basal
You can
cell.
do it if you want. Okay.
I thought it was a basal cell.
Yeah, so that looks like basal, and what kind of pattern?
Like a superficial or like
Yeah.
a nodule, depending on which cut you're looking at.
Yeah, like superficial in that piece. Over here, it's definitely not just superficial, right? That is. So typing helps tell you for treatment. So if it's superficial, you know it's going to keep going laterally. Like garlands at the holiday, just keep going lateral. And they have a high recurrence rate in some areas, most commonly temple. You'll see these guys where 3/4 of their temple is ED and C scar, and there's still basal cell at the edge, right? Because that superficial BCC just keeps coming back at the edge, and their face is more and more scarred as it gets treated that way. So that's actually superficial BCC in the temple is one of the areas where what we think of as a more indolent type of BCC can be very destructive, disfiguring. Centrally, the growth pattern has changed. It's spiky in areas, so it's infiltrative. And then what about over here? That's keratinizing and full of what look like ducts.
It looks like more squamization to some of the area. And then
So either
under an ulcer, can't you usually see when it gets eroded like that? Can't you see squamization and a more aggressive growth pattern to normal basal cells?
yeah, so you bring up a few things. One is you might have just some squamous metaplasia of eccrine duct and an ulcer base. This looks like a little more than that. More aggressive ulcerating types of basal cell often have squamous differentiation. But that's usually foci within the tumor. This is more like a side-to-side, where this side is standard basal, and then that side is an ugly squamous tumor with duct differentiation. So raises the possibility, as opposed to rises up, raises the possibility of a collision tumor, or sometimes those are called true basosquamous. When you have something that looks squame with duct differentiation, it tends to be more aggressive because it's behaving more like an Adnexal carcinoma. Could be a malignant acrospiroma with duct differentiation. You also, if you're around the parotid, you have to think of mucoepidermoid carcinoma, adenosquamous, all of those variants that tend to be more aggressive. So this is something that's going to grow very far lateral kind of have to feel it out with a curette. Be careful if it's in the temple because there's higher recurrence rate. It's also spiky infiltrative, so depending on the site, may need Mohs. And then you have an aggressive squamous tumor that's going to be particularly aggressive because of the duct differentiation. If you're sitting over parotid or parotid tail, retroauricular, be very careful because you might actually be getting into a salivary gland tumor there. That's common for us. The most common scenario for a derm seeing it is a retroauricular tumor that has duct differentiation, and you just keep chasing it right into the parotid because that's where it started.
So it looks like you have a little serum crust here with some neutrophils.
Yeah, and when you said the word serum crust, do you see a lot of pink serum, or is it mainly just a subcorneal pustule?
Yeah, it looks like a subcorneal pustule.
Yeah, subcorneal pustule without a whole lot of pink serum.
Mm-hmm.
So if it had lots of serum, I'd be more likely to think impetigo.
Mm-hmm.
Subcorneal pustule in the distinct absence of serum, more likely to think.
You have your Capus differential, but like a pustular psoriasis or Sneddon-Wilkinson.
So pustular psoriasis, Sneddon-Wilkinson, a lot of which is IgA pemphigus. So that's absolutely correct. So you're thinking this is probably not a secondary scale crust, which usually has serum. This is probably more likely a primary pustular process that's subcorneal, like a psoriasis or a Sneddon-Wilkinson subcorneal pustular.
Let's see. Punch biopsy.
And what's that pink stuff there?
Oh, looks like fibrin.
Yeah, some fibrin, probably some serum too, right? So this is different from the last one in that you see epidermal necrosis, you see fibrin, you see serum. More likely now that those neutrophils and that crusting is secondary rather than a primary process.
Okay, impetigo.
So you might well think impetigo, something excoriated. Let's see what the history, I don't think I can even read that. What does it say?
BP urticarial phase.
BP urticarial phase. So the crust we're seeing is all secondary. Out to the side, there are lots of EOs. I'm not sure I can really say they're lining up at the DE junction, but here you have a little spongiosis with EOs. So that area, there's so much secondary change here, I don't think this would be fair to ask as a question, but it's certainly real life where you see, what catches your eye centrally is all secondary change, and the primary change is off to the edge here where you have spongiosis with EOs. So what's your differential for spongiosis with eosinophils?
Herpes, just, was it H's, herpes gestationis?
Yeah, so happy, so herpes gestationis.
Arthropod or allergic contact dermatitis.
So arthropod, allergic contact ACD.
It's like pemphigoid, pemphigus.
Pemphigus, pemphigoid.
IP.
Incontinentia pigmenti and erythema toxicum when you don't catch the follicle in the section. So, you could work your way through it if you saw that. Certainly if you saw all those EOs off to the side, saw some of them lining up at the DE junction, or saw the eosinophilic spongiosis, we probably would have gotten there.
So we have a well-encapsulated nodule in the dermis.
So it does kind of have a fibrous capsule, so it's been there for a long time. And what do you think the stuff, the blue chunky stuff is in there?
Is it serum?
So serum's red.
Right. So it's kind of like a purplish.
Yeah, blue and chunky. Anyone? Yeah, calcium.
Calcium. So calcinosis cutis.
Calcinosis cutis. It's not particularly perforating through the epidermis like a subepidermal calcified nodule on the chin of a 10-year-old kid. So this is more like a dystrophic calcinosis cutis than an old person might have.
Colloid milium? Would that material have a different color? Like a
Colloid,
whiter
colloid milium is kind of amphiphilic to red. Amphiphilic, you sort of see shades usually of amphiphilic and red in colloid milium, and a transition between the elastic fibers and which are more bluish, and the colloid milium that becomes progressively more reddish, similar to amyloid and fissured.
Mm-hmm.
So, central, subepidermal, bulla, tons of EOs, potentially BP.
So subepidermal bulla, lots of EOs.
Maybe just arthropod too.
So BP, but you have to think of arthropod, include scabies in arthropod.
Mm-hmm.
And then what other immunobolus, anytime BP leaves your lips, what has to follow it?
EBA.
EBA. Because 20% of what looks like BP is actually EBA, and those are all the ones that don't respond to treatment, all the ones that are perineoplastic probably. All your problem BP patients probably aren't BP. They're mostly in that 20% that's actually EBA.
So punch biopsy looks pretty squared off.
So fairly squared off punch biopsy. Tell me about space between collagen bundles.
There's not a whole lot there.
Yeah, there's not a whole lot, or histologically we say there ain't none. So no space between the collagen bundles. Collagen's kind of, hyalinized, spread out.
It's like a morphia.
Yeah, like a morphia. The nodular lymphoid infiltrates definitely go with morphia. You commonly see them at the base, at the dermal subQ junction, but you can see them above the area of sclerosis as well. So very good.
Sorry. Subepidermal bulla.
Yep.
Yeah.
Plus,
Predominantly eosinophils. There's some newts scattered in there too.
yeah, so some newts, predominantly EOs, subepidermal bulla.
I feel like we're in the kind of same differential. Think about BP, think about EDA.
Yeah, BP, EBA, arthropod type of differential. And so what might your next step be to sort them out?
I would want to make sure they got immunofluorescence in it.
So immunofluorescence, and what would you expect maybe to see?
So hopefully we'd see linear IgG deposition. You look for the in-serrated versus U-serrated.
So linear IgG, and much of the time we don't have to do salt split skin anymore because you can look for N or U-serrated pattern, N serrated going with
BP.
and U-serrated going with EBA. Very good.
Do we have collagen 7 here? I know some people are starting to do that instead of
I don't know if we
got it today, Rob.
collagen 7.
I don't think so.
I know we've had it other places I've been where you use it for blister mapping. We use it for inherited EB too.
Dr. Pollitt would sometimes ask for collagen 4.
So collagen 4 you can do, collagen 7 you can do, collagen 7 is the target antigen in both EBA and bullous lupus. And collagen 4 I think we do have here. I don't think we have collagen 7.
Ours didn't work that well.
In eBay.
Okay, Justin, what do you think?
Oh, it's neat. So there is a little bit of a split that's occurring. It looks secondary. There's a lot of necrotic keratinocytes and an acute horn. So So this could be a drug eruption. There's a little bit of not really a lichenoid infiltrate, but there is some granular lymphocytes, maybe some neutrophils included as well.
And how acute or chronic is the process?
It's an acute horn.
So it's an acute horn, so acute horn with dead reds.
You're thinking fixed drug, EM, some sort of drug process, or erythema multiforme.
Yeah, I think that's a great differential. So fixed drugs, so you'd look, we've got acute corneum, you'd look, is there any papillary dermal fibrosis? And I can maybe talk myself into there being some ropey collagen above the postcapillary venules, so that would bring fixed drug into the differential. In the absence of that, EM is more likely, just drug in general, as you mentioned. Combinations of interface and psoriasiform, anytime you have mixed patterns, it can't decide if it's spongiotic or interface or psoriasiform. Always think of drug viral syphilis, anytime you have those mixed patterns. For syphilis, you look at a busy dermis, neutrophilic crust, maybe plasma cells, endothelial swelling. Don't really see that here. So, you'd want to go for history, and drug, fixed drug, EM are all good things to have in the history. This one was labeled EM. With that little bit of ropey collagen, I'd broaden the differential a little histologically.
Looks like a blue.
So why does it look like a blue?
It looks like it has its own sclerotic collagen, which
So
is
it's
different. It's also wedge-shaped.
So it's wedge-shaped, brown pigment, and it has its own distinct ropey sclerotic collagen that's different from the regular dermal collagen. Very good for blue.
Spindle cells are kind of like
Atypical spindle cells, and is there a Grent zone, or are they slammed up against the epidermis?
Mostly slammed.
So what would be the differential for a tumor of atypical spindle cells slammed against the epidermis?
Squame, sarcoma, atypical fibers,
And melanoma. Very good. So conveniently, for atypical spindle cells slammed against the epidermis, your mnemonic is SLAM, spindled squame, leiomyosarc, atypical fibroxanthoma, melanoma. This one has visible mitoses, including atypical, like a Mercedes-Benz tripolar mitosis there. So that would be your differential. What the world is your oyster. You can have anything you want. What stains do you want?
So you can do a keratin stain for squame.
So a keratin stain or a P63 would be, good squame type markers. What else?
Like actin and desmin for the leiomyosarc.
So leiomyosarc, we used to do a lot of smooth muscle actin, but most of God's children are smooth muscle actin positive, so it's a little too sensitive, not specific enough. So we're kind of back to Desmin, Cal-Desmin, H-Cal-Desmin as being more specific muscle markers. And then for melanoma, S100 would be very reliable and spindled. What's the other reliable stain in spindled melanoma? Anybody? SOX10, exactly. So those are your two. For spindled or desmoplastic, you cannot rely on H&B, you cannot rely on MART1 or Melon A, but both SOX10 and S100 are pretty reliable. And then any specific markers for AFX?
Diagnosis of exclusion.
So it is a diagnosis of exclusion, as you said, but they're almost always CD10 positive. They're usually S100A6 positive because that picks up histiocytic things, and procollagen 1 is often positive. So there's some markers, they're not entirely specific, they're not entirely sensitive. So as you said, it's, remains largely a diagnosis of exclusion.
Is it your experience, Dr. Elston, that the procollagen 1 stain is really kind of hard to read? Because it usually kind of faint?
It is somewhat finicky, yeah. So, we had it, and we had it actually working very well, where I was happy with it. But a lot of places it's a finicky stain. So lots of labs try to bring it up, but it's just hard to get it validated and up and working for that reason. And that probably contributes to its lack of sensitivity and specificity.
So we have a lot of there's something going on at the DEJ.
So there's something going on at the DEJ. So what's going on at the DEJ here?
Vacuolization and loss of the DEJ altogether there in areas.
Yes, so destruction of the basal layer, savate bodies, band-like infiltrate.
Which is called lichenoid.
So it's a lichenoid dermatitis in something broad on sun-damaged skin.
That is worrisome for a lichenoid regression of melanoma.
So you would worry about lichenoid regression of melanoma, and in fact, when you go over to this area,
What part of that look like?
see some zipper sign and some things that have melanin in them, suggesting melanocytic nests. So we're thinking lichenoid regression of melanoma. Tell me about the middle. This scar in the middle. Big, thick scar in the middle with nodular lymphoid aggregates. So spindle cell proliferation with nodular lymphoid aggregates. Anybody? Yeah. Desmoplastic melanoma. So you have what looks like big, thick scar in the middle. You want to be real careful. Has there been a recent biopsy or surgery here? In the absence of that, so, we want to confirm that that's melanoma, so I'm going to get an HMB, right?
False.
False. What would I get?
A SOX10 or S100 as mentioned by Dr. Cook.
A SOX10 or S100 as mentioned by Dr. Cook. Very good. Thank you for saving me, because I almost ordered that HMB, and that would have been bad, right?
It happened to anyone.
Are these the lymphoid aggregates right there? Well,
Yeah, exactly.
Where
So
exactly are they?
these are
Right there.
like this.
That one.
So if you've got something that looks like scar or spindled anything with nodular lymphoid aggregates, that buys an S100 or SOX10 to rule out desmoplastic melanoma. The worst case of that I saw was a woman who was 53 years old, had a massive area of tumor in her back that she had had since age 14, slowly growing. And every time a physician tried to talk her into a biopsy, she said, it's been biopsied 3 times when I was young. And they always said it was benign. It was read as scar, and then it was read as, well, something fibrous but benign. Review of those biopsies from when she was, a teenager, had spindle cells, nodular lymphoid aggregates, all S100 positive. And she now, these are slowly growing infiltrative tumors. Within 2 years, she had died. It did finally undergo kind of a metamorphosis back to an epithelioid melanoma that metastasized, went to bone and marrow and widespread. But she had that, indolent growth, and it was essentially unresectable because it was almost her whole, dorsal part of her body was just replaced with the tumor grown for so many years. But you can see how, no one reading any of her material wanted to hurt anyone. But they saw a very bland, fibrous thing, and they didn't pick up on the lymphoid nodules, which were there. So, that's one of the things we beat into people because you don't want to miss that one.
So this looks like a squame to me.
So it looks like a squame. Are these spiky or are they kind of rounded?
Maybe around it. I was going to say there should be irritated seb with it, but I thought there was something to do over on that side over there with like a little bit of acantholysis happening. So I usually don't think of that with irritated seb.
Yeah, so that's, the atypia, little acantholysis raises the specter of squame. When you look at the cells that are infiltrative, what are they?
Are there TOs in there? I mean, neutrophils in there, sorry.
No, I think you're right. There are a lot of EOs in there. So there's some neutrophilic microabscesses and lots of EOs. In the squamous world, if this were an eruptive squamous proliferation, that would favor what?
That would be because of the KA.
Yeah, keratoacanthoma. But this person actually has multiple plaques. If you look at her, both of her forearms, her flexures, are just verrucous plaques studded with pustules. So she has these flexural verrucous plaques, sides of the neck, popliteal, antecubital, just verrucous plaques studded with pustules, and you see the pseudoepitheliomatous hyperplasia with eosinophilic abscesses, Pemphigus vegetans, and that's actually a true story. So her initial eruptions were thought to be KA, type of squame because they were popping up, multiple, they had EOs, they had neutrophil microabscesses, but of course her IF was beautiful chicken wire immunofluorescence, and this is all Pemphigus vegetans.
So I'm trying to figure out, is this sebaceous differentiation or more acrospharyngeal differentiation? It kind of looks like it's peppered with lymphocytes, so I was thinking about spiroadenoma, but...
So it looks peppered with black lymphocytes, like a spiroadenoma. It's a great big blue ball. I don't see good duct differentiation. Blue with ducts, especially blue with thick red ducts, is usually sebaceous. This doesn't have the thick red ducts. Maybe a little focal, little white circles, but there's certainly not the blue nodule with thick red ducts, thick red circular ducts of sebaceoma. It does have dark gray cells at the periphery, paler gray cells to the center. As you said, it's peppered with jet black lymphocytes. I think spiroadenoma, you're dead on.
Looks like these dermal pink nodules, very bland.
And so bland, uniform, dermal pink nodules, do they palisade or distinctly not palisade?
Not palisade.
Distinctly not palisade.
It's like a dermal duct tumor.
Like a dermal duct tumor of Winkelmann, which is a type of...
acrospiroma.
Acrospiroma poroma. That half the chapter is acrospiroma variants, right? Clear cell hydranoma, nodular hydranoma, dermal duct tumor, hydroacanthoma simplex, poroma, solid and cystic poromas. They're all acrospiromas, right? They all differentiate towards eccrine duct. So what they have in common is they are more pink than blue because they have ample pink cytoplasm. They never palisade. They usually have some visible little white circular ducts. They're bland, and they often have necrosis and cavitary change, often with clear cell degeneration, like a clear cell hydranoma. This one doesn't particularly have that, but dermal duct tumor of Winkelmann, very good.
Angiofibroma?
Like an angiofibroma, which is probably what it is. Cousin to angiofibroma, with these two-tone epithelioid cells. Kind of sits between angiofibroma and dermatofibroma, epithelioid histiocytoma. So, that's a 13A positive benign dermal proliferation. So angiofibroma, epithelioid histiocytoma with the thick collagen bundles, thick ropey collagen. Those are probably my top two. It's not quite as onion skin as a sclerosing perineurioma would be. It does have some dilated vessels, so it may have been called an angiofibroma. What did it get called? It got called an epithelioid histiocytoma. But if you called it a angiofibroma, that would be just fine. It's a benign fibrohistiocytic proliferation. Wouldn't matter which of those two things you called it.
Look like some areas of nesting.
Areas of nesting.
Over here, a lot of pigment seems to involve adnexal structures, maybe like a congenital nevus.
Yeah, kind of diffuse interstitial as much as it is nested. So I would say probably congenital nevus, and they said combined nevus. It certainly has a congenital pattern. Combined, they're probably saying that there's some dendritic in here. Maybe there's a little bit in here, dendritic melanocytes, but certainly a benign nevus and congenital pattern. So I think I would have just called it congenital, just as you did.
Looks like some porokeratosis up there.
Porokeratosis, where do you think you are? With these nodular,
On the leg.
vascular, probably shin, right? Anterior lower leg. So, reactive vascular change characteristic for shin, those cannonball-like angioplasia like you see in stasis, a lot of hyperkeratosis.
Is that a coronoid lamella?
That is a coronoid lamella off to the edge. Very good. Remember, center of poro can look like anything. You're just seeing reactive changes characteristic of lower leg, and then the coronoid lamella at the edge. That's it. We're done. Well done.
Thank you. Can I ask a question about this thing?
Sure. Yeah. Let me before we violate HIPAA. Let me